Me to talk about spot stenting or full metal jacket. What's best on the data? Can we have the slides up? Potentially. Pretty please. I feel like I'm talking to my kids now. Slides up, slides up. There you go. Okay, I'm out of Boston. These are all of my disclosures, some of which are germane, but we'll chat about those as we go through this. So the idea of, I just want to throw you the data because I really think that we need to understand where we are and why we're here. This is the original trial that got into New England Journal with 100 patients, and it was the first trial after Grunzig did his angioplasty in '78, first trial of randomization between angioplasty and stenting. This was Eric Menard's group out of Vienna, and it's the absolute trial. And they looked at claudicants versus, and some with CLI, but most of them had claudication. And they tested about a 10 centimeter metric lesion length. About a third of the patients were occluded. And I'll draw your attention, this is backwards, this is European data, so they look at restenosis. So a large number is a bad thing and a low number is a good thing. And they did it an as-treated thing to the left there with the square on the left. On the right side of that screen is the restenosis as treated. And then if you look as stented at 12 months, which is the far right, you can see about a 70% restenosis in angioplasty and about a 37% in angioplasty arm that failed. And this was the first time that we actually saw angioplasty trump or get trumped by stenting. What's important here is that the clinical outcome at 2 years presented the next year in Circulation had no difference between endoprosthetic and angioplasty. So remember, you're treating a clinical outcome of claudication. Let's move forward by about 10, 15 years, and now this is the Zilver PTX. Remember, 5 centimeter metric. This is their 1 year primary patency out to the 18-month time frame. And again, Zilver, double randomized trial, optimal balloon, suboptimal balloon, looking at drug effect, looked at benefit in this 5 centimeter metric. But this is a seminal paper because they're the first one and only one to go out to 5 years to primary patency. This is a primary patency at a PSVR, very conservative, 2.0, 66 versus 43 for angioplasty. But you can see those levels are maintained, but they're relatively flat, so it's a fairly soft landing. This is the poor man's restenotic range, which is the TLR. So clinically driven TLR, you can see a nice 85% versus 71, a maintained p-value, barely above 0.06, but a delta that was still fairly profound. One trial that I helped lead with Ken Rosenfield here is the pivotal trial on Superb. I put it in here because now we're going to look away from drug. We're going to look at stents. The question is long versus short stents. This was driven towards about an 8 centimeter and 8.5 centimeter metric with a PSVR of 2.4 or less. But in this group, we had a fair number that had calcification in this trial, and this is the Superstand. The Superstand is an interwoven 6 tines of nitinol. What we found in our Kaplan-Meier curve is on the far end of 14 months was an 86.1% primary patency on this 8 centimeter metric. What we don't see is beyond that, we went to TLR. So this is one of our failures in this trial. But if you looked at the TLR outcome at 3 years, you can see that this one comes out at 82%. The delta on this is only 7% over 3 years, the best in class when it came to stenting outcomes. But importantly, you've seen this in various metrics, that the outcome of this stent, if you deploy it nominally or compress it a little bit, the primary patency on this is actually quite good. It's about near 90%, and it's regardless of lesion length in a various myriad of registries, but this was the pivotal trial for the United States. However, if you deploy this poorly and overextend it, it does very poorly. If you look to the right of your screen, you can see a clear decline on the lowest metric, again, a TLR outcome. 42% at 3 years was really not terribly good. So you got to prep this lesion very well. I was involved and helped lead a group for Medtronic who really gave us unfettered access to their trials. And we looked at patterns of restenosis. And why is this important? Well, we want to see failure modes. And we came up with a 5, not the Tosaka instant restenosis, because we do a lot of non-stenting today, but looking at restenotic patterns beyond stenting. And we came up with a level of 5 groups from focal to occluded. Why is that important? Well, when you look at stenting and look at the metric of the original index and compare it to restenosis, you can come up with some ideas of how people do when it comes to either focal or diffuse or occluded. So the green at the top is an occluded artery, and when it is occluded, they come back more often occluded. If you look at the focal disease on the left, orange, when it's orange, it comes back generally orange again, so focal. So focal begets focal, and occluded becomes occluded. But if you look at it with the basic metric of how you did it, that is angioplasty versus atherectomy versus DCB for Medtronic or bare metal stent, you can see a myriad of ways people can enter focal and they can come back out as occluded, or they can come in as occluded and they come back out as focal. This is really where we live and breathe, because not every patient is the same when it comes to these pivotal trials. So at 12 months, when it comes to drug-coated balloon, we have this at 78%. If you look at the TLR, a very flat 97. If you look at the CD-TLR rates, they're still separate, but they're truncated now, down to about 6 or 8% at 74 versus 65. So what about focal stenting? Now, the best focal stenting you'll see is the TAC system. And the TAC system, they had a randomization that I didn't appreciate until I read the manuscript, which is in the short lesions or in the long lesions. So a very small group, about 32 patients, had 1 centimeter TACs placed in various locations for dissection. And if you look at their outcomes, it's a little bit of roundsmanship. They give you these very long, flat lines, which you have to look to the right of every one of them. So the top is the TLR metric, very flat and very good outcome, both for short on the A side, and the B panel is the long lesions. And you can see a clear decline. Remember, Kaplan-Meier's are actuarial tables. They only start assessing people when they come in through the window. You can't die until you get assessed that you've died. Here, it's you can't assess restenosis until you're assessed as a restenotic. So on the far end is where you see those stair steps. That's when people start coming through the window. And that's one of my biggest pet peeves when we report primary patencies. So if you look at their long lesions, which is down, the primary patency, which is down below, you look at that line on A, short lesions are fairly short, very soft landing when it comes to the 12-month outcome. But look at the long lesions. If you put more TACs in, you tend to get longer restenosis, or at least interventionally, you get longer swaths of restenosis. And if you look at the total lesion length, on the far end, it was about 5-6 centimeters, and the long lesions were about 15 centimeters. It's in the center there with the target lesion. So in the 10 minutes I had, what's best? I got to tell you, at the end of the day, we have a myriad of devices that are available for treatment in the SFA and popliteal. Supera has really demonstrated a fairly good outcome, and I believe it's the best in class for non-drug-eluting stent. The TOBA 3 demonstrated both long and short lesions work well with accepted primary patency. So as the title suggests, what's best? Well, I think it's debatable. I think it's up to you as to what you feel is more important. Is it focal restenosis that's good, or is it diffuse restenosis that's good? And what do you want to have in your hands? And what we expect in a durable outcome, whether it's short TAC or long stent, should be equivalent to each other, though the failure mode is of restenosis is generally not something we want to encounter, but is generally best if it's focal and not diffuse. So I want to thank you for your attention.